von Hippel-Lindau, and other NET-associated syndromes. Hello, this evidence-based content is prepared by Saboor Khan, fellowship-trained consultant surgeon, and if you or someone you care about has been told they have a rare hereditary syndrome connected to pancreatic tumors, conditions like von Hippel-Lindau disease, neurofibromatosis, tuberous sclerosis, or MEN4, I know this can feel overwhelming. But today, we're going to demystify these conditions and explain exactly what they mean for you and your family. By the end, you'll understand how these genetic syndromes affect your pancreas and other organs, why genetic testing matters, and know exactly what surveillance and treatment options exist. These hereditary syndromes represent a unique category of conditions where a single genetic change, inherited from a parent or arising spontaneously, predisposes you to developing tumors in multiple organs throughout your life. Think of your genes as instruction manuals for your cells. When one of these specific genes is damaged, it's like having a typo in a critical safety instruction, allowing certain cells to grow into benign or sometimes cancerous tumors. What makes these syndromes particularly important is that they're autosomal dominant, meaning there's a 50% chance of passing the condition to each of your children if you carry one of these genetic changes. Von Hippel-Lindau disease, or VHL, is caused by mutations in the VHL gene. Pancreatic neuroendocrine tumors, or NETs, occur in up to 10% of patients with VHL disease. Here's where it gets interesting. Unlike some other syndromes, VHL-associated pancreatic NETs typically don't produce hormones that cause symptoms. They're what we call non-functioning tumors. This means they're often discovered during routine surveillance imaging, rather than because they're causing noticeable problems. Now, VHL affects more than just the pancreas. The syndrome is characterized by the development of tumors and cysts in multiple organs, particularly the brain, kidneys, and eyes. That's why patients with VHL require comprehensive surveillance beyond just pancreatic monitoring. The genetic defect in VHL disrupts how cells respond to oxygen levels, creating an environment where blood vessels grow abnormally and certain tumors can develop. Neurofibromatosis type 1, known as NF1, is caused by mutations in the NF1 gene on chromosome 17. Functioning pancreatic NETs are exceptionally rare in NF1. Only 8 cases of insulinoma or somatostatinoma have been described to date. That's about as rare as it gets in medicine. But here's what you need to know about NF1. This is primarily a neurocutaneous disease, affecting both the nervous system and skin. The hallmark features include multiple café au lait spots. Those are flat, light brown skin patches, axillary freckling, cutaneous and plexiform neurofibromas, bilateral Lisch nodules in the eyes, optic gliomas, and bone alterations. Interestingly, about half of NF1 mutations arise spontaneously, meaning they occur for the first time in the affected individual without being inherited. If you have pancreatic insulinoma or somatostatinoma, your doctor should suspect NF1 if you also have at least 2 typical clinical features of the disease, or 1 clinical feature plus a first-degree relative, parent, sibling, or child with NF1. Tuberous sclerosis complex, or TSC, is caused by germline mutations in either the TSC1 or TSC2 genes. Pancreatic NETs are uncommon in TSC patients, but their frequency is higher than in the general population. When TSC patients do develop hormone-producing pancreatic NETs, insulinoma, tumors that produce excess insulin causing dangerous low blood sugars, is the predominant type. TSC is fundamentally a tumor predisposition syndrome characterized by hamartomas, benign tumor-like malformations, and occasionally malignant tumors developing throughout the body. These affect multiple organ systems in unpredictable patterns, which is why comprehensive surveillance is essential. Multiple endocrine neoplasia type 4, or MEN4, is an extremely rare autosomal dominant syndrome caused by mutations in the CDKN1B gene, which encodes a protein called P27, or cyclin-dependent kinase inhibitor 1B. This syndrome mimics MEN1 so closely that it is often only distinguished through genetic testing. MEN4 is characterized by primary hyperparathyroidism, overactive parathyroid glands causing high calcium levels, pituitary tumors, and gastroenteropancreatic NETs. Among the 9 cases of pancreatic and duodenal NETs described in MEN4 patients so far, most were non-functioning, but 3 were duodenal gastrinomas, tumors producing excess stomach acid. The functioning pancreatic NET frequency in MEN4 is approximately 8%, with gastrinoma being the most common type. Approximately 17% of all pancreatic NETs are inherited. Here's the critical takeaway. The hallmarks that should prompt genetic counseling include multiple primary tumors in multiple organs, early onset before age 40, and characteristic inheritance patterns. It's crucial for physicians to take a detailed medical and personal family history in every patient presenting with a pancreatic NET. Molecular testing for these syndromes should include next-generation sequencing, followed by a quantitative assay called multiple ligation-dependent probe amplification. This comprehensive approach catches not just simple mutations, but also larger genetic rearrangements that might otherwise be missed. All these genetic syndromes are autosomal dominant conditions, meaning you only need one abnormal copy of the gene from one parent to develop the syndrome. They're usually highly penetrant, which means if you carry the mutation, you're very likely to develop features of the syndrome at some point, though the expressivity, how severely and in what ways the syndrome manifests, varies considerably between individuals. If you're supporting someone with one of these syndromes, this 50% transmission risk to children makes genetic counseling and family screening absolutely essential. Early recognition of relatives carrying these mutations is of utmost importance due to this high probability of transmission and the possibility of genetic anticipation, where some hereditary conditions become more severe or appear earlier in successive generations. If you've been diagnosed with a pancreatic NET and you're under 40 years old, have multiple tumors, or have a family history of endocrine tumors, request a referral to a clinical geneticist for comprehensive evaluation. Don't wait. These hereditary syndromes require multidisciplinary care teams, and getting the right specialists involved early makes an enormous difference. Document your complete family medical history, going back at least 3 generations if possible. Note any relatives with tumors, particularly kidney, brain, pancreatic, parathyroid, or pituitary tumors. This information is invaluable for genetic counseling. Should I undergo genetic testing for hereditary tumor syndromes? If you have any of the red flags mentioned, the answer is likely yes. What surveillance protocol should I follow? Patients with hereditary syndromes require organ-specific surveillance tailored to their particular condition. For example, VHL patients need brain and kidney monitoring, while those with hereditary pancreatic NETs need pancreatic and duodenal imaging. How do we monitor my pancreatic NETs? For MEN1-related non-functioning pancreatic NETs smaller than 2 cm, observation with close imaging surveillance using MRI alternating with endoscopic ultrasound is the current standard. Surgical resection is generally advised for tumors larger than 2 cm, or those showing growth of more than 0.5 cm yearly. What about my family members? First-degree relatives have a 50% chance of carrying the same genetic mutation. They should undergo genetic testing and appropriate surveillance even before symptoms develop. Seek urgent medical attention if you develop symptoms of hypoglycemia, low blood sugar, such as confusion, sweating, trembling, or loss of consciousness. This could indicate an insulinoma producing dangerous amounts of insulin. Watch for severe, uncontrolled endocrine symptoms. If you have a gastrinoma causing Zollinger-Ellison syndrome and experience severe abdominal pain, persistent diarrhea despite medication, or signs of gastrointestinal bleeding like black stools or vomiting blood, these require immediate evaluation. Clinical aggravation with unexplained weight loss should prompt urgent reassessment, as this may indicate tumor progression or high-grade transformation. Patients with hereditary diseases like MEN1, VHL, and Neurofibromatosis type 1 should be followed according to the organ of the primary tumor, for example, the pancreas and duodenum. Surveillance intervals are shorter for patients with high-grade tumors. Large tumor burdens such as liver involvement exceeding 30%, extensive disease, aggressive behavior with progression within a few months, severe uncontrolled endocrine symptoms, or chromogranin A levels exceeding 10 times the upper normal limit. For MEN1 patients specifically, non-functioning pancreatic NETs 2 cm or smaller may be observed with surveillance imaging, while surgical resection is recommended for tumors larger than 2 cm. Management decisions for tumors between 2 and 3 cm should be made case by case within a specialized NET multidisciplinary team. Let me quickly recap. Rare hereditary syndromes like VHL, NF1, TSC, and MEN4 can predispose you to pancreatic NETs alongside tumors and other organs. Your next step: if you have any red flags, young age, multiple tumors, or family history, request genetic counseling this week. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. The European Neuroendocrine Tumor Society provides comprehensive guidance papers on both functioning and non-functioning pancreatic NETs in hereditary syndromes. The International Consensus Statements on MEN1, VHL disease management, and diagnostic criteria for neurofibromatosis type 1 offer detailed syndrome-specific information. Full links are in the description below.